You want to be there? No. So what do you do? What's the number one way we prevent pneumonia, community acquired pneumonia?
Wash your hands.
Okay? Cover our mouth when we cough. Wash our hands. So we also, as we plan for care of the patient with pneumonia, we want to prevent complications, right? Let's talk about improving airway clearance. 2 to 3 liters a day, unless contraindicated. Humidification. If we give someone oxygen, it has to be humidified, right? We teach them to cough. We do chest physiotherapy if we're trained and it's indicated. We change their position. And we give oxygen therapy, and as I said, we'll talk about the modalities more on Thursday. We give oxygen therapy based upon the client needs. If someone can tolerate nasal oxygen with the nasal cannula, and they're more comfortable with that, we're going to give them those as opposed to a mask, which can make you kind of claustrophobic unless you need a mask. We're going to promote rest. We're going to cluster our care. We're going to avoid overexertion. And anybody I've ever known who had, Jessica was talking about fatigue, who had, walking pneumonia or community-acquired pneumonia, was given pneumonia and sent home. They do talk about they have to rest. So that might mean involving someone else. If you have a mother who has pneumonia and she has small children, you may have to figure out some way to help her mobilize her resources so that she can get the rest she needs, because she won't heal, she won't get better. What is semi-Fowler's versus high Fowler's versus supine position in the bed? Semi-Fowler's, okay. So 35 to 40, and then high is all the way up, right? So you want to make sure, you may, when you got them home, you may need to demonstrate before they go home how to position themselves with pillows. Remember I showed you all also floating your arms. It just helps expand the lungs. So these are simple things, but when they're not done, they become big things. One little thing is just one little thing. One little thing and one little thing and one little thing and one little thing can make a mess or prevent a mess, depending upon whether you are tuned into these details. Okie dokie. So I think that's about it for right now. We've been going an hour to the middle of the longer. Let's go ahead and move on to aspiration. Risk factors for aspiration. Aspiration pneumonia. How we prevent it in the hospital. We keep the head of the bed elevated, particularly if we have someone who's getting tube feedings. Okay? Remember, everybody in the hospital is compromised. Everybody in the hospital is at risk for confusion. And really, everybody in the hospital is at risk for aspiration simply because they're in the bed. Okay? So we want to elevate the head of the bed. The client starts to vomit. We talked about this already. We want to turn them to their side. We want to make sure that if we have to suction them, we don't stimulate the gag reflex. If they've had a bronchoscopy or any upper respiratory procedure, if they've had endoscopy, any procedure that numbs the back of the throat, puts them at risk for aspiration because they don't have a gag reflex. So we want to make sure we don't feed them or give them anything to drink too quickly. Tube feedings. How do we assess for tube feedings? How do we check tube placement? X-ray initially. Air. But if you insert air, where could it be? It could be in the lung. You could hear it over, So, aspirate, right. And then we observe. If we have someone who, I think this is what, maybe we talked about this the other day, we have someone who's getting tube feedings. We have a stroke patient who's getting tube feedings. And it's continuous tube feeding. And he begins to get a little bit tachypnic, and he begins to get a little bit of fever, and he begins to cough. And his sputum production's kind of tan, and it's the color of the fluid in the tube feeding? Maybe the tube feeding has become displaced. Whoops. And that can happen. So that's why it's real important when you have anybody on tube feedings that you're getting frequent vital signs and you're listening to their lungs and you're making sure the tube placement is good. Ooh, what do you think happens if you put a tube feeding in your lungs? Ooh, yeah, is that a great medium for bacterial growth? Aside from the fact that they're just drowning.
That's aspiration pneumonia.
That's aspiration pneumonia, yep. That's for sure. And rehabilitation therapy for swallowing. Who needs rehabilitation therapy for swallowing? Stroke patients, right. Right. Laryngectomy patients later on because they're taught a special way to swallow. But we have many more patients in the hospital who experience, at least where we are, strokes than we do who experience laryngeal cancer. And who teaches clients how to swallow? Speech therapy. So, who was with me the other day when we had a stroke patient who was swallowing better in the afternoon than the morning? Somebody in here. We had a patient who had a recent stroke, and you can watch them. If they get treatment fast enough, they can regain their losses pretty quickly. And this gentleman in the morning had a much more pronounced droop in one side of his face that morning than he did that afternoon, because all day long he kept trying to exercise, and they were able to block the obstruction. Yes,
My patient with a droop, but he wasn't swallowing because he had a.
he had the droop, but his droop got better, didn't it?
After you make a face of that.
Make faces at him. Yeah. Teach people to make faces. Moves a lot of muscles. All right, let us talk about pleurisy. What are the pleura? What are those pleura? Right. We have the visceral pleura, the parietal pleura, and those are the two membranes, the covering they help keep the lungs against the chest wall, right? And can they get inflamed?
Yes.
And what does it feel like when someone has pleurisy, Joy?
Oh, it hurts.
Tell us how it hurts.
Stabbing. It's like
Stabbing.
And it hurts when you breathe in, and just you don't want to breathe in.
You don't want to
Try
breathe
not
in. Does it hurt
Just
worse
take- Yeah, it hurts a lot worse
with inspiration than expiration?
with inspiration, especially
Okay.
inspiration. mainly.
Inspiration. And where was the pain primarily when you had pleurisy?
It was
Last
like
year.
here. It kind of felt just right,
Tell us. I'm the only one who can
in
see.
my back.
In your back, on your back?
Yeah.
Did it
yeah.
migrate? Did it rotate? Did it radiate?
Pardon?
Let's rotate the pain. Did it radiate? Did it migrate? Did it move?
No, it didn't really. It just felt like I had a knife just stuck into my back.
Was it sudden? Like suddenly, or did you? Was it kind of okay?
Sudden. Woke up with it.
Okay.
Sudden, couldn't breathe.
Couldn't breathe. Okay, couldn't breathe well. And so, what was the treatment?
Well, I was in England, so we called the doctor, and he actually came to the house,
Mm-hmm.
and he gave me an injection, and I really don't know what he gave me, but it just stopped it immediately. I don't know if it was,
Drugs.
yeah.
Right.
I know it was drugs, I just don't know if it was some kind of relaxant or what it was, but he gave me something that it just stopped it immediately.
In your arm, intramuscular, or
Yeah.
your butt? Okay.
Miss Tom,
And they didn't. Yes.
I had it once and it was all over. It was
Yeah.
staying all
Everywhere?
over my chest.
Did you wake up with it?
I was 15, I thought I was having a heart attack.
It hurt
Yeah,
everywhere.
I woke up with it
Yeah.
and it was just like a burning, awful, like stabbing and burning sensation.
When chest tubes are removed too, it irritates the pleura and it's a very burning pain.
Awful. It is awful.
It's not fun. So what happens is everything rubs together when you're breathing. Okay, and that's what causes the pain. Pleural effusion, a collection of fluid in the pleural space. You know, there's not really a space with those membranes. They're right next to one another. But different conditions can cause a space to be created. Fluid gets in there, pus gets in there, empyema, pus gets in there. And so you've got an inflammation of the pleura that's caused by the artificial creation of the space when fluid accumulates. And that's what we mean by pleural effusion, okay? Usually we don't get effusions unless we've got something else going on. That's why when we say it's secondary to another disease process, that's what we're talking about. If you have a big pleural effusion, you got a liter of pus around your right lung, do you think the lung can expand? Not the way it would normally expand. In addition to the pain, you don't have the physical space for the lung to expand. Okay, and so what does that do to your oxygenation? Decreases oxygenation, right. And so if you've got a big pleural effusion, Are you gonna be, what's the word for short of breath, the medical word for short of breath? Dyspnea, right, you're dyspneic, okay? We describe that as a nurse as dyspneic, increasing dyspnea. Okay, what's that?
I can never pronounce that word.
I can't pronounce it. Dyspnea, like the dyspnea. Dyspnea. Okay, empyema, pus, collection of pus. Thick, purulent fluid in pleural space.